pathology. I have 8 years experience in postgraduate and undergraduate teaching, and I have 15 patents, 5 got grant, and I have 13 publications and national and international. Today we are just going to deal about the topic of WBC, lymph node, spleen, and in part 1 already we have discussed about the WBC disorders, and the topics we have covered earlier is hematopoiesis, disorders of white blood cell, lymphadenitis, neoplastic proliferation of white blood cells, neoplasm of mature T cell and NK cell, plasma cell neoplasm, and related disorders. If you have not seen the part 1 class, kindly check the below description. In part 2, we will be dealing with the Hodgkin lymphoma, myeloid leukemia, myelodysplastic disorder, myeloproliferative disorder, and myelodysplastic disorder, and splenomegaly. Next, we are just moving into the Hodgkin lymphoma. It has 5 types. One will be the nodular sclerosis, second will be the mixed cellularity, third will be the lymphocytic rich, fourth will be the lymphocyte depleted, and nodular lymphocytic predominant. In nodular sclerosis, it's a B cell origin neoplasm where you will be having the fibrosis due to cytokinins, interleukin 13, TGF beta, and it is associated with EBV virus. It occurs in the young age group. Female are more affected. You will be having RSL in the peripheral smear. In bone marrow, you will be having extensive fibrosis, and in cytogenetic abnormality, you will be having EBV association. It will be highly positive for CD13, CD15, and PAX5. Mixed cellularity, here the association of EBV will be more than 70%, and here it is a tumor which occurs in old age group. Males are more affected, and peripheral smear you will be having eosinophilia, and bone marrow you will be having effacement of the plasma cells, and in cytogenetic study you will be having EBV positive RS cells. It is positive for CD30, CD15, and lymphocyte rich classic Hodgkin lymphoma. It's a variant of classical Hodgkin lymphoma where reactive lymphocytes predominantly. EBV association will be 40%, middle age group will be affected, and males are more affected than the females. In cytogenetic study, EBV and LMP1 association will be studied. CD30, CD15, and PAX5 will be positive. In immunophenotyping method, lymphocyte depleted classic Hodgkin lymphoma, EBV association will be more than 80%, and older adults will be affected, that is more than 60 years of age group. Males are more affected than the females, and here the lymphocyte depleted classical Hodgkin lymphoma will be more commonly seen in the immunocompromised state. So, peripheral smear you will be seeing anemia and eosinophilia. In bone marrow, the common marrow involvement will be seen, that is the eosinophils will be involved, the lymphocytes will be, that is atypical lymphocytes, and lymphoblasts will be seen in bone marrow. Cytogenetic, you will be having EBV, LMP1 complex karyotypes, and immunophenotyping, that is CD30, CD15, PAX5 will be positive. Nodular lymphocytic predominant Hodgkin lymphoma, it is a dystonic entity which is not associated with EBV infection. Young males are affected, and here cytogenetic abnormality will be elicited will be translocation of 2,5 or BCL6 rearrangements, and immunophenotyping CD20, CD45, BCL6 will be positive. Hodgkin lymphoma, here you can see this is a lymphocytic predominant type. Here you can see the lymphocytes surrounded with lymphohistiocytes and popcorn cells. These are the popcorn cells. Another will be the mixed cellularity where you will have both the lymphocytic cells or popcorn cells. Second, we are just moving into the myeloid leukemia, which is divided into acute myeloid leukemia, myelodysplastic neoplasm, and myeloproliferative neoplasm. In acute myeloid leukemia, this is the major subtype classification. The classification is divided into 2 types. One will be with genetic aberrations, another AML will be with defined by differentiation, AML minimally differentiated, AML without maturation, AML with maturation, AML with myelomonocytic maturation, AML with monocytic maturation, AML with erythroid maturation and AML with megakaryocytic maturations. These are maturations are graded according to the blast percentage and the cell's predominancy. So, this is a picture showing acute myeloid leukemia, blast cells with prominent nucleoli and irregular cytoplasm. This is the another picture showing the typical R rods in myeloblast. Myelodysplastic syndrome. Here it is categorized into MDS with low blast, MDS with SF3B1 mutation, that is ring sideroblast, MDS with isolated deletion of 5q, MDS with increased blast and MDS with increased blast 2 and MDS hypoplastic type and MDS with biallelic T53 inactivation and MDS unclassified. Here it is the MDS is always affected in the elderly age group above 60 years, and here you can see a macroovulocytic anisopoikilocytic changes. In bone marrow you will be seeing ring sideroblast according to the various and the subtypes of MDS. And it will be always the cytogenetic abnormality shows a deletion of 20q and immunophenotypic. Most of the MDS will be highly positive for CD34 and CD117 will be positive. Second will be the myeloproliferative neoplasms, which includes chronic myeloid leukemia, polycythemia vera, essential thrombocythemia, primary myelofibrosis, chronic neutrophilic leukemia and chronic eosinophilic leukemia. In chronic myeloid leukemia, there will be translocation of 922 and Q34, Q11, that is BCR-ABL fusion gene, tyrosine kinase activity and uncontrolled myeloid proliferation. It occurs in the age group of 40 to 60 years. Here you will be having marked leukocytosis and immature cells like myelocytes, metamyelocytes, bond form, everything will be elicited in the peripheral smear, and the lab score will also be decreased, and bone marrow it will be a hypercellular garden party appearance of cells, that is mixture, all number of immature cells proliferation can be seen, like that blast more than 20% or 10%, promyelocyte, myelocyte, metamyelocytes, all the components can be seen. In lab investigation, total leukocyte count will be elicited, lab will be decreased and Philadelphia chromosome will be positive in cytogenetic study and BCR-ABL positive will be elicited. Polycythemia vera, here you will be have JAK2V617 mutation. It occurs in the age group of 50 to 70 years and males are more affected than the females. Here in the RBC you will be having normocytic normochromic, but the leukocyte count and thrombocytosis will be seen. That is increase in the WBC and the platelets will be elicited. Here it's a hypercellular smear showing erythroid, myeloid and megakaryocytes will be increased. And lab investigation, increase in the hemoglobin and hematocrit will be increased and RBC mass will also be increased. The EPO, the typical findings of the polycythemia vera is EPO will be decreased and increase in the uric acid and vitamin B12 will be elicited in polycythemia vera. Essential thrombocythemia, here you will be having JAK2 mutations. It occurs in the age group of 50 to 60 years. Marked thrombocytosis will be there. Giant platelets and mild leukocytosis will be there. Megakaryocytes hyperplasia will be encountered in the bone marrow. And lab investigation shows increase in the platelet count more than 4,50,000 and you will be positive for BCR, ABL, absence will be there. In primary myelofibrosis, JAK2 mutation will be encountered. 50 to 70 years will be affected and the male and female are equally distributed, and leukoerythroblastosis, teardrop cells, dactrocytes and nucleated RBC are seen in the peripheral smear. Bone marrow shows hypercellular, myeloid hyperplasia and minimal dysplasia. The lab investigation finding will be the dry tap, the cell count everything will be decreased, like decrease in the WBC count, decrease in the platelet and decrease in the RBC count. They will be presenting with a picture of pancytopenia. Chronic neutrophilic leukemia, from the name itself it is clear that there will be highly proliferation of the neutrophils. There is persistent mature neutrophils, that is more than 80%, and no basophils will be there. Hypercellular, myeloid hyperplasia and minimal dysplasia will be seen in the bone marrow. Here the WBC count will be increased and it will be predominantly replaced with neutrophils. Here the lab score will be increased. Chronic eosinophilic leukemia, here it occurs due to the mutation in the JAK2, PDGFRA and PDGFRB, and age group is adults are more affected and eosinophilia will be there and dysplastic eosinophils will be there in the peripheral smear. Bone marrow hypercellular with eosinophils, filled with eosinophils, and here the eosinophil count will be more than 1.5. The absolute eosinophil count will be double the amount of normal, and vitamin B12 value will be increased and the tryptase value will also be increased. So this is the picture showing the band form of neutrophils, band form myelocytes in the peripheral bleed, which is seen in chronic myeloid leukemia, and this is the essential thrombocythemia. Here you can see the Jane cells, and this is the myelofibrosis picture where you can see the teardrop cells, that is called as dactyrocytes, lymphocytes and the nucleated RBC. So the final topic is spleen and causes of splenomegaly. The exact function of the spleen is phagocytosis of the blood cells, that eating up of the unvoid cells. Second will be the antibody production. Third will be the hematopoiesis, sequestration of the formed blood elements, and there are many classifications for splenomegaly. The broad classifications are infectious causes, congestive status related to the portal hypertension, lymphohematogenous disorder, immunological inflammatory conditions, storage disorders, miscellaneous disorders. In this, we are just going to highlight what is the difference between the congestive splenomegaly and the splenic infarct. Congestive splenomegaly is nothing but it occurs due to chronic venous congestion, and it occurs due to the increase in the pressure in the splenic sinusoids and dilation on extravasation of the RBC, fibrosis and hemosiderin deposition, that is gamma antibodies will be seen. Microscopically you will be having the hemosiderin laden macrophages, fibrosis of the red pulp and the gamma antibodies, and grossly the spleen will be cyanotic, firm and fibrotic spleen. In splenic infarct it occurs due to injury, it is due to injury which is leading to ischemic necrosis of the splenic tissue due to arterial occlusion. Arterial occlusion causes ischemia, and ischemia results in coagulative necrosis, and healing will be taking place by process of fibrosis or calcification. You will be having microscopy, you will be seeing coagulative necrosis, neutrophilic infiltration and fibrosis and calcification. Here grossly the spleen will be looking like pale wedge shaped infarct. Thank you.